Okay, let's start the meeting. Welcome to the Grey Bruce Board of Health meeting for Friday, October 28th, 2022. We'll start with the roll call, please, Mary.
Sue Patterson,
Present.
Alan Bartlett,
Present.
Brian Mill,
Present.
Brian O'Leary,
Present.
Chris Peabody. Chris Peabody, Luke Charbonneau,
Here.
Selwyn Hicks,
Here.
Helen Claire Tingling,
Good morning, everyone.
Janice Jackson, Nick Saunders,
Thanks, Mary. We do have quorum. So I'll ask if there are any amendments to the agenda.
Madam Chair, if we can amend the item under the section of the act in Canada to potential legal litigations.
Okay, yes, I will amend that when we get to that item 12.1. Any other amendments? Seeing none, I'll ask for a motion to approve the agenda as amended. Luke, Brian O'Leary, all in favor? That's carried. At this time, I'll ask if there's a disclosure of pecuniary interest or conflict of interest. And I do not see any, but if one should arise during the meeting, you may declare it then. Item 5 is educational notes, and continuing with our theme of professions in public health, we're going to highlight the dental health educator. Last month, we did the registered dental hygienist. So qualification for the dental health educator position requires a minimum of a one-year college diploma in dental assisting, a written board exam through the National Dental Assisting Exam Board, and healing arts radiation protection approved for taking x-rays. A dental health educator must have good oral and written communication skills, good knowledge of dental assisting clinical procedures, and good organizational and planning skills. Dental health educators must possess a good working knowledge of electronic medical records and other ministry recording systems, such as the Oral Health Information Support System and Healthy Smiles Ontario Workbook. Mandatory training includes a medical device Reprocessing Association of Ontario certification, as well as a current CPR certification. The dental health educator has two primary roles in the health unit. First, dental health educators accompany and assist the dental hygienist with stool screenings in the delivery of the stool screening program. Dental health educators must follow the annual screening steps for both the Blue Water and Catholic school boards. This includes circulating information letters to the schools for parents to review before the screening, creating screening sessions, writing out dental report cards for students, and completing paperwork for parents. Second, dental health educators assist the clinic dentist in the provision of restorative treatments in the delivery of the Ontario Seniors Dental Care Program and Healthy Smiles Ontario. This includes chairside assisting, charting, taking x-rays, and reprocessing and sterilizing dental equipment and instruments. Confirming and booking appointments and taking medical histories are other responsibilities they must have. Dental health educators also assist the dental hygienist in preventative clinics for clients. Last but not least, dental health educators contribute to strategies and planning that support healthy community development and the delivery of oral health education to various community groups. Are there any questions or comments about dental health educators at the health unit? Another important job with the unit. Okay, that's another profession. All right, item 6 is adoption of minutes. So we have the Board of Health regular minutes from September 23rd. Any discussion or questions, comments? It's moved by Al Barfoot, and I need a seconder. Brian Millen, all in favor? That's carried. Thank you. Item 7 is correspondence and news releases, and Dr. Arrow will start with the correspondence.
Thank you, Madam Chair. We have 5 correspondences. They come into chronological order here, but there is a function of the first and the last one that is very similar. It's related to communication from boards of health to the ministry to request increased funding for the Healthy Baby, Healthy Children. We had endorsed similar communication from Sudbury Board of Health in previous meetings, so my recommendation is to receive the 3rd and the 4th correspondence from Peterborough. Similarly, we had endorsed similar communication to one of them, and we had decided to receive the other previously. So the recommendation is to receive both. The second correspondence is interesting in a way that it's calling on the provincial government to mandate using life jackets on recreation boats to prevent injury from drowning or submersion injuries that has some effect, or some, depending on the season and the year, could be significant effect on the emergency department, had caused death in Ontario. So there is a need for discussion about that item. We know we can prevent incidents with certain policies. The question is how much intrusiveness public health measures need to have to deliver that prevention. So more or less for Greg Bruce, we have many beaches, and definitely this is something that will affect us. And the recommendation here to receive, just because such legislation or such policy, in my opinion, needs thorough evaluation about the consequences, about whether the measures are too intrusive or least intrusive. So at this point, I'm recommending to the board to receive, and we can do an evaluation for Greg Bruce over the past 10 years to see if this warrants the support. However, I would appreciate discussion around the table to direct us whether we need to support this, then do the evaluation after.
Thank you, Dr. Era. I should ask online, Helen, Claire, and Chris, you can hear us okay? Give me a thumbs up if you can.
I can, Madam Chair, but Janice is still trying to get online. I don't know what's going on with, if somebody can let her in, or maybe it's a problem on her end.
I'm hearing it's a problem on her end, but
Okay.
we'll keep trying. Thanks for that, Chris. All right, any discussion with about the life jackets direction? Selwyn?
Thank you, Madam Chair, and I hear the comments of Dr. Era. But I can't help but think that this is an almost no-brainer. We can prevent loss of life if people simply use a life jacket, not just have it, but wear it. I remember the days when, kids would sit in the back of the parents' what were those station wagons, right? Some of them were even rear facing, and it was nothing for kids to be without a seatbelt in the car, and for people to drive around without a seatbelt. And I feel like we're light years behind with vessels. I mean, it's a dangerous environment. Sometimes you're just having good old fun, and split second things happen. I have a very good friend who lost a child, a woman from law school. She lives in Ottawa, and her child just disappeared, gone. And days later, they recovered him. And had he been wearing a life jacket, I go camping every year, canoeing, and the rule is you put your life jacket on every time without failure, adults, children, doesn't matter. You could be a lifeguard. You have to wear your life jacket if you're in our group. It's just the way it is, and it works. Everybody wears it. Everybody, it's just like you almost feel naked without it. It's kind of like getting in the car today. It's just automatic. You reach for that seatbelt. So I get the comments, and I hope that we will get to the point. My understanding is the regulations get caught up in legalese. So waters are federal domain because they're navigable. And is it federal jurisdiction or is it provincial jurisdiction? And then there's US and Canada. And in the US, by the way, they're way ahead of us in terms of this legislation. But I just hope that common sense can prevail. To me, it seems like a no-brainer that we strongly encourage or even legislate that if you're going to be in a vessel, you're going to put on a life jacket. So that's it for me.
Very good. Dr. Eric?
Thank you for the comments. Definitely, I hope my comments didn't convey that I'm not supportive of life jackets. There are certain complexities. One of them, what you mentioned, the legislation and whether it's federal or provincial or local. The main perspective in my mind, there is enough education on the importance of whether there is enough communication and regulation or policies in private companies or education to parents that would suffice the use of life jacket instead of making it mandated through government or legislation. If the education that's in place right now is sufficient actually to prevent the absolute majority of it, what is the increased benefit of legislating it? And I'm not saying there isn't increased benefit, I'm saying we need to evaluate if there is going to be room for improvement or not with legislation. Like you look at the helmet for bicycle use. For children, I'm absolutely supportive of that. For adults, is there increased benefit because most people wear it, or if they decide and they're not going to wear it unless it is legislated, and if you legislate it, they might not even use a bicycle. So there is a harm of losing the exercise because there is intrusiveness in it. So the percentage of people who would benefit or change their behavior because of that legislation, if this is not evaluated, it might really backfire. Another example of unintended consequences of the policy, if right now there is legislation federally to have life jackets on boats, that's mandatory, not to wear it. If people wear it, are they going to be less responsive in the incident of an accident? Somebody to be able to run and get the life jacket and send it to the person who fell or to move. I don't know the answer of this. So that's what I'm saying, we need to probably evaluate it. I realize the discussion at the board that suggested this put basic statistics, the number of people who died in the past 10 years, I believe 20 in Ontario a year. Well, there could be more evaluation to be done. And again, I'm not belaboring it, I guess. If the decision from the board to support, I still believe it is a reasonable approach. The Board of Health usually was there on the conservative side. But I'm saying we will follow up with an evaluation of the board decides.
Thank you. Comments? Luke?
Thank you, Madam Chair. I think it's an interesting discussion, but it's really an issue that's outside the well-known jurisdiction of the local Board of Health. I mean, it's a matter to be dealt with by Transport Canada, navigable waters stuff, and there's a lot of interest, particularly on every pleasure craft. Everybody has to wear a life jacket. I've been talking. So everyone on a cruise have to wear a life jacket. I think it's as I say, it's a matter of well-being of the local jurisdiction. I would much rather that Dr. Era's staff will be spending his time researching on that and really have to be dealt with by provincial governments. If it's a major concern, I'm sure they will do it, but I'd be happy to receive it.
Thank you. Other comments? Alan?
Thanks, Madam Chair. I think it falls into the common sense file. mean, I have a pontoon boat. We go to the lake pretty much every day, and anybody that wants to wear a life jacket, there it is. You know, legally, I have to have so many on there, and they're in there. All the kids, we make them wear them for sure, but it comes down to, you know, legally, you have to have them there. They are there. If you want to wear it, it's there. So the common sense part prevails on that. So I agree with Luke. I think there's other issues that Board of Health should be spending their time on versus something that's out of our control.
Thank you. All right, so.
Madam Chair, excuse me, I'm just having some trouble hearing. My speakers are up to their loudest, but I don't know if everybody else, I don't know if you could sort of bear in mind that I'm struggling a little to hear the comments. Thank you.
Okay, was it Luke you were having trouble with?
No, I could hear Luke, I could hear Selwyn, everybody else kind of going in and out. Dr. Ara in particular, I'm struggling to hear.
Okay, good to know.
Probably didn't have any trouble hearing me.
You have a very clear voice.
No, I mean, I hadn't said anything.
Very clear silence.
Yeah.
All right,
Yeah.
do we have consensus? We will receive this at this time? Nodding heads, yes, okay. So all of the correspondence will be received for information, so we'll continue on with the news releases. And I see Denise is on the line. Welcome, Denise.
Hello, thank you, Madam Chair, and through you. There are 7 media releases on today's agenda. On September 21st, Public Health issued a media release after birds at Harrison Park and Owen Sound tested positive for avian influenza. Public Health followed up with Parks employees who had contact with infected birds, and no human cases of the virus were reported. On September 23rd, Public Health issued a media release after receiving the first laboratory confirmation of influenza in Grey Bruce of the 2022-23 flu season. The timing of this positive case indicated an earlier than usual start to the flu season. We also issued media releases on the Healthy Communities Conference, which took place September 28th in Owen Sound, new food affordability data compiled by Public Health, as well as Falls Prevention Month, which is in November. And the Grey Bruce Health Unit issued a media release on Public Health's partnership with District A9 of Lions Club International to provide free in-school vision screenings for senior kindergarten students at Blue Water and Bruce Grey Catholic District School Board schools during this school year. And the final release issued last week spoke to the availability locally of bivalent COVID-19 boosters for all Grey Bruce residents aged 12 and older. Bivalent boosters are available at public health and GoVax clinics in the area, as well as through primary care providers and at pharmacies. And that concludes the media releases on today's agenda.
Thanks, Denise. Are there any questions or comments about the releases? Seeing none, I need a motion to receive the news releases and correspondence as presented. A mover, I have Helen Claire, and I'll take Luke. All in favor? That's carried. Thank you. Item 8 is staff presentation, and we have infectious disease fall preparedness, and we have Jillian Jordan, who is going to present the information. Welcome, Jillian.
Hello.
Hello.
All right, I'll just share my screen here, actually. All right, so good morning, everyone. Thank you for having me. I'm Jillian Jordan. I'm the manager of the Infectious Diseases and Sexual Health Programs. And today I'll be speaking about fall preparedness. So I was actually with you back in March to talk about COVID-19, our pandemic progression, and the response of the ID team. And that is largely what I'm here again today to talk about. But before we jump into things, I did want to give a quick overview and a major shout out to my team, the infectious diseases team, for all the other work they've been engaged in. So COVID has definitely brought case and contact management to the spotlight, but this work has been going on prior to COVID as well as throughout the duration and still is ongoing now. For example, the team investigates cases of salmonella or E. coli to try and identify a source and mitigate risk, provide education to those cases to help protect their health and the health of others. Or, for example, case management of STIs, where contact notification and treatment helps to break the spread of transmission. So ID staff manage hundreds of other cases of infectious diseases per year on top of our COVID cases, as well as outbreaks. And 2022 has been especially interesting with the emergence or popping up of monkeypox, as well as avian influenza, which we both dealt with here locally. So COVID and respiratory outbreaks definitely continue to dominate our time. And as we head into respiratory season today, I'll be speaking to our current situation in regards to COVID-19 and influenza, our winter projections for what the respiratory season might bring, as well as our preparedness activities that we're engaged with on the ID team.
Jillian, okay,
Yeah.
good. I was just gonna say your slides weren't progressing, so.
Oh, I think we're on track here. Okay, so
Okay, good.
current situation for COVID-19. Good, we're on the right slide. So here's a quick snapshot of our COVID situation as of week 41. So that's October 9th to 15th. So we've been seeing a bit of a shift in activity over the past few weeks. So for the past month or two, I'd say August into September, we were seeing approximately 10 new cases per day, average of around 5 active hospitalizations. And then since early October, we've essentially seen a doubling effect. So we've crept up to close to 20 confirmed cases per day. Of note, these are cases in our highest risk populations. So those who are seeking out that confirmatory PCR testing, which would be people in hospital or folks residing in long-term care or retirement homes. We've also seen a pretty proportionate increase in hospitalizations and deaths, as well as outbreaks. And this upwards trend isn't unique to us here in Grey Bruce. It's being seen across southwestern Ontario as well as the rest of the province. So influenza is something actually we haven't been talking much about over the past 2 years. Here in Grey Bruce for our 2022-2023 season, which when we speak about respiratory seasons, they run from September to August each year. We saw our first case in mid-September, and actually as of this morning, I checked, we're up to 20 confirmed influenza A cases locally, as well as have added 1 influenza B. And as we look at the past 2 years, especially 2021-22 and 2020-2021, you can definitely see that the pandemic impacted how influenza circulates through all those public health measures we were taking. If we go back to the 2018-2019 season on the far right, that's likely most best representative of a typical flu season we'd see here in Grey Bruce, where our first case is identified sometime in mid-November, with influenza B following a bit later, and on average around 200 to 250 confirmed cases identified each year. So since preparing these slides, as I mentioned, we've continued to see cases pop up. We've also had already a confirmed influenza A outbreak here locally at one of our hospital sites, which has since resolved quite successfully. But looking at this, it seems fair to say that flu has re-entered Grey Bruce, and after being quiet for the past 2 years. So a big chunk of the planning that we're doing for this season is factoring in just that. And then to wrap up an overview of our current situation, I figured I'd bring up our outbreaks. So here's an overview of our current and past seasons. So like flu, the pandemic definitely impacted how our outbreak seasons have played out, with again, 2018-19 being a standard outbreak season, where we routinely see about 40 to 50 outbreaks per year, with the bulk of the activity concentrated in those mid-winter periods. And pre-pandemic, we'd see a whole array of organisms identified, such as influenza, but also RSV, rhinovirus, human metapneumovirus. And sometimes an outbreak would be declared just because of an increase of respiratory activity in which no agent would be identified. So comparing and contrasting with our current respiratory season, we're likely set to surpass our annual average for past years within the first few months. And our previous outbreak season in that 2021-22 respiratory year, we managed just over 120 outbreaks in total. So it's been definitely busy for our group. And actually, in speaking of comparing and contrasting, aside from just numbers, I think many would wonder, how do these compare just as far as how outbreaks have played out? What does it look like case-wise, deaths, hospitalizations? So COVID compared to some of the outbreaks we would have seen in the past. And for both COVID and non-COVID outbreaks, progression and outcomes vary greatly. So pre-pandemic, we would sometimes see quite mild outbreaks with limited spread, maybe a case or two, and outbreaks being declared over within a couple of days. But we'd also see the odd outbreak with wild scale impact and several deaths. So reflecting on our recent COVID outbreaks, we've seen outbreaks where we've had 90 to 100% of residents on a wing or ward impacted, sometimes many of which would remain asymptomatic or only fall mildly ill. However, we've also seen some COVID outbreaks where maybe they're just a case or two here or there, and we do experience a death. So I definitely don't want to downplay death, as the loss of a loved one is hard for families, as well as their families within those homes. When we're handling a particularly long and drawn out impactful outbreak, we can tend to see an increase in people passing within these homes. However, when preparing these slides, I wanted to reflect back on my own experiences managing outbreaks pre-pandemic. And I think back to one specifically, which went on for 3 to 4 weeks. We saw many cases come out of it. And during the course of the outbreak, we actually ended up seeing 5 or 6 deaths, I think, which to us seemed like a huge number. So we sat down with the home and reviewed whether or not that rate was above and beyond what they'd usually be expecting. And as part of their long-term care home, they did provide quite a bit of end-of-life care. So some of those deaths were expected. And that is very much what we see in some of these COVID outbreaks as well. So with this being about preparedness, this is what we're preparing for and why. As we've anticipated and are obviously already seen, this winter isn't likely to be just a repeat of our past years, and it's also not likely to play out like a regular pre-COVID season. So we are definitely expecting continued COVID-19 circulation at maybe rates that are higher and lower, or wax and wane throughout that respiratory season. It's also expected that we'll see co-circulation of COVID, flu, or other respiratory viruses. And then on top of that, it's expected that as a population, we may have reduced immunity to some of those bugs we used to be exposed to on a more seasonal basis, thanks to how well some of those community level public health measures worked throughout the pandemic. So this creates the potential, which we're most interested in, for multi-agent outbreaks in long-term care and retirement homes, which can be kind of complicated or challenging to manage. So looking at preparedness on 2 different levels, first being provincial and second being local, I did just want to start off that the focus of our preparedness efforts are very much on preventing morbidity and mortality, especially in those most vulnerable populations, versus trying to eliminate COVID altogether. So at the end of August, we received new case and contact management for COVID-19 community cases with some of the biggest changes to date. The new guidance focuses on staying home when you're sick versus those set timelines of 5 and 10 and 20 days. or requiring people who are asymptomatic or otherwise well and testing positive to isolate. The new guidance does indicate that if you've been sick and are recovered, or if you're positive and well, if you're entering in the community in close indoor spaces where distancing is not possible, the recommendation is to wear a mask during that 10-day period, just to protect others if you are shedding that virus. We've also recently seen updated outbreak guidance, so for long-term care and retirement homes, which aims to safely roll back some of the more intensive outbreak measures like wide-scale testing and isolation that we know were quite hard on residents' social, emotional, and physical well-being for a good chunk of the pandemic. Additionally, there are continued provincial efforts to ensure access to vaccination and antivirals to help reduce disease severity for those who are infected. Locally, we have a couple things going on. Regarding outbreak prevention and management, so that active work that my team is engaged in, it's obviously a major part of our role for facilities like hospitals, long-term care, retirement homes, but also those adult care homes or community living type settings. If an outbreak is declared, we communicate with them on a daily basis, sometimes hourly, it seems, to walk them through key outbreak management steps to help ensure favorable outbreak outcomes. This is on top of ongoing communication we have with our partners 7 days a week to chat through all sorts of various infection control scenarios, various things to support them in either prevention for outbreaks or recovering after one has been resolved. In periods like this, where things are a bit busier, we sometimes need more hands on deck. And something we've built into our team is flexibility or scalability in our workforce, where we have others on standby who stay appraised and up to date on our current situation, as well as our outbreak management protocols, that on their downtime when things are slower are able to flex in and out of our program to engage in some other really important public health work. For example, our sexual health clinic, which we reestablished back in July. I do know Lindsay Johnson, the vaccine manager, provided a recent presentation quite in depth about immunization. So I'm not going to go into depth there, but as the ID team, though we don't administer vaccinations, we do continue to emphasize the importance of influenza and COVID vaccines, as well as timely access and initiation of antivirals, again, COVID and flu, in the event of an outbreak, again, to lessen disease severity and lend themselves to more favorable outcomes when outbreaks are declared. Communication is a huge part of our role, as was highlighted in that previous slide. So we are on a daily basis talking with all our homes and partners. We have, I think, close to 60 in total as far as long-term care and retirement homes, and that doesn't include our hospitals, as well as some of these adult care settings, of which there are numerous. We keep them up to date also on any new guidance or key events that do occur, such as our first case of influenza, so they're aware of what's happening locally and are able to adjust their practices to meet the potential risk. We continue to have our monthly meetings with long-term care and retirement homes, something we started early on in the pandemic that have been a huge hit. And when we ask facilities about whether or not they find them valuable and wish for us to continue, it is always a resounding yes, which is really great to hear. And we do throw in the odd special events such as webinars, or recently we held a train the trainer workshop where we help train non-nursing staff from some of these adult care homes in safe specimen collection to help remove some barriers for testing when these homes do go in outbreak. And then finally, reporting. So we keep the public up to date on our local cases and active outbreaks. You can find this information on our Grey Roos Health Unit website dashboard, but also at a provincial level, the Public Health Ontario dashboard, which includes information around cases, deaths, hospitalization, vaccinations, and outbreaks, as well as what's happening for influenza across the province, is updated every Friday at 11:30. So in an hour here, you can sign on and check out what's going on across the province. Internally, though, we do engage in a lot of reporting that directly feeds into these databases. So extensive outbreak tracking for cases and agents, as well as monitoring who's in hospital for what, as well as, if any deaths are identified. And by keeping up on top of this reporting, though we're not doing direct case and contact management, by providing this information regarding COVID and influenza, we're able to inform our actions locally as well as at the provincial level as well. So though there's potential that this upcoming respiratory season will be busier and probably different than we've seen before, we're hopeful our strong partnerships with our facilities, as well as the steps we're taking to prepare for various scenarios, will result in favorable outcomes, especially for those most vulnerable. So those in long-term care, retirement home, and hospital, for our residents in Grey Roos. All right.
Thank you, Jillian. Good presentation. And I'll ask if there's any questions or comments for Jillian. Alan?
Thanks, Madam Chair. Yeah, great presentation, Jillian. I'm almost to the point of being a little bit scared here with some of those numbers that I guess I'll refer to Dr. Ayer for his comment. Are we going back up again on number of cases? Is this looking to be scary this fall?
Through you, Madam Chair, in the past 2 weeks, we have seen increase in the circulation of the virus. Definitely, that's reflected in the number of new cases that we're testing in the high-risk sector, increase in the number of hospitalization, increase in the number of outbreak. But it is not out of proportion to what we're prepared for or projected for the fall and the winter. The two reassuring factors. One is the level of immunity for COVID that comes from repeated vaccines and from repeated infections is relatively high. The second factor is Omicron in general is less severe than the previous variants. Many of the deaths that are caused by or that have been detected and reported related to COVID have been happening with COVID, not because of COVID.
Thank you. Brian Millen?
Thank you, Madam Chair. Thank you, Jillian, for the report. I'm wondering on your the current situation with COVID-19, is there any correlation between the uptick in cases and the level of vaccination in the community? The uptake of vaccination in the community? I'm hearing anecdotally that it's not nearly high enough or where it needs to be to kind of head off that uptick in cases. Perhaps Dr. Ayer or Jillian, I'm not sure who wants to take a run at that.
Through you, Madam Chair, I wonder, Jillian, if you can put the slide where comparing outbreaks or number of cases of influenza from previous years with COVID. This one, thank you. So you look at, for example, I know the example here is influenza, not COVID. Historically, the number of influenza cases for the entire year is 81, or here is 14. The procedure with influenza is to test 4 samples in the long-term care. So if one of them is positive, we stop testing. So the fact that we had 14 cases right now, those are the ones that are tested. So there will be way more. With COVID, something happened in the province of Ontario and in many other jurisdictions where everybody's being tested. The home will be tested multiple times. In the scientific approach to public health management of outbreak, as soon as we identify COVID, we should stop testing because the rest of it is COVID. So when you see these numbers exploding in the number of patients or new cases, relatively, it's still not as significant as it should be comparing to apples to oranges in this case. So that's one part of the answer. If you can go to the next slide. You look at these outbreaks, some of these outbreaks in 2020, for example, the upright corner. Each outbreak had a number of cases, one or two, most of them, I think. That's the definition of outbreak. And that is the success of preventing transmission to the rest of the home. With Omicron, it is impossible. It's almost impossible to do that. It's extremely infectious. But at the same time, like Jillian mentioned, most of these residents wouldn't even know that they had COVID. And if they have any symptoms, it's minimal. Many of them are end of life or because of age or other comorbidities, unfortunately died. But, you know, is this death because of the infection or death with the infection? And that's where, at this point, you know, look at the data since Omicron started, the number of deaths because of COVID is not as significant as it is optically seems.
Well, if I might, all that being said, does that mean that vaccinations aren't nearly as important as they were early in the pandemic?
I wouldn't say that through, Madam Chair. With Delta variant, with other variants, the vaccines were very essential. Even with Omicron, the fact that people had multiple boosters and they can stay up to date, the effect of the disease or severe disease is minimized. All these variants, all these vaccines, whether they prevented transmission or not, they actually prevented severe disease.
Right. Okay, thank you.
Selwyn?
Thank you, Madam Chair, and thank you, Jillian, for the presentation. My question is, in your presentation, you talked about influenza A and B. The question is a very simple one. When you receive the flu shot, are you protected against A as well as B?
Jillian?
Yeah, so the flu shot each year does contain both strains, yes.
Thank you.
Okay. And while you're there, Jillian, rhinovirus, can you just explain that for everyone?
Yeah, rhinovirus is just the common cold, basically. There are lots of different respiratory agents. So pre-pandemic, we had seasonal coronavirus, again, a cause of the common cold, but rhinovirus is quite a common respiratory infection that we saw pre-COVID, and now it's making its way back on the scene.
Thank you. Other comments or questions? Luke?
Yeah, thank you, Madam Chair. I just, if you go back to the other slide, that current situation outbreak slide. And I just was interested in comparing the pre-pandemic year 2018, 2019 to where we're at now, just so I understand the difference, or maybe there's no difference there. It's just so if you look at those confirmed outbreaks in 2018, 2019, pretty low, you know, that was just influenza and other rhinovirus and stuff like that, I suppose. Now, getting to 21, 22, much, you know, if you just look at those two charts, you would think we're in a much worse situation. I just wonder if you could, I'm just not certain that impression is accurate. And so I just wonder if you could clarify the difference between those two charts and what's driving it. It's just we're doing a better job of monitoring these outbreaks and picking them up more, and so that we're getting a better sense, or are we actually, is that actually as bad as it looks?
Through you, Madam Chair, the chart 21, 22 is because of Omicron. So as soon as the infection enters a home, almost everybody's infected. And as soon as the community, there is circulation of Omicron in the community, we've seen outbreaks in the homes, because it's almost impossible to prevent the introduction of the virus into the home. Are there more outbreaks because of Omicron? Yes, there is. The reassuring part that these outbreaks didn't result in the same level of death that the previous years resulted in. For example, in 2018 with influenza, if the outbreak for some reason was not managed immediately and the prophylaxis antibiotic was, or the antiviral was given immediately, it's not uncommon to see 6-7 deaths in the home if there is no antiviral or management of the outbreak. With Omicron, we know that there isn't treatment to it that's provided to people unless they end up in a hospital. There hasn't been this level of deaths. Definitely there hasn't. So again, the number of outbreaks is true, and that's not related to the increased monitoring. We monitor influenza as much as we monitor COVID in homes, but the impact is not as much.
So that chart that was influenza and Omicron stirred together, right? Is there influenza showing up in that 21-22 chart? And if there is, how much?
So based on my recollection, I believe we only had one influenza outbreak in the previous respiratory season. So that would have been one of the outbreaks represented in this chart. We've seen very limited influenza circulation over the past 2 seasons.
And are you, through Madam Chair, are you concerned at all about the early onset of influenza and potential for this outbreak situation to worsen because of the 2 viruses working together in the long-term care homes? And you mentioned influenza being, or at least historically being risky if not controlled very quickly in terms of deaths, and we're not seeing it there yet, and the outbreak numbers are already pretty high. Are we going to be seeing a worse case than most years, like in 2018, 2019 with influenza? And when you layer Omicron on top of that, are we going to end up in a serious situation where we're seeing more death than, obviously we want to see no deaths, but where we're seeing a higher than expected rate of death?
Through you, Madam Chair, for the first question, with the public health measures in 2020 and 21, influenza epidemiology curve dropped down to 0. So that's many of these, like Jillian mentioned, many of these outbreaks in 21 are not related to influenza. The second question, am I concerned about the impact of 2 viruses at the same time? Let me unpack it. It has 2 layers to it. Yes, I'm concerned related to the management, because with the flu, we need to provide antiviral immediately, and we usually provide it to everybody in the home. Now, the circulation of COVID with influenza, when you pick up COVID, does this mean that the rest of the home is infected with COVID or potentially influenza? So we have to give, we might end up in certain scenarios where we might have to be conservatively giving antivirals for influenza when not everybody's actually, it's not an influenza. Or if we identify COVID, do we need to stop testing for influenza? We probably will gonna have to face these technical questions, but at the end of the day, the management of the outbreak is very conservative, that we most likely will be erring on the side of the conservatives, I'm repeating myself, to give antiviral for influenza if there is a chance of influenza in that home. The combination of 2 viruses at the same infection is not there. Usually the body would respond to one virus, and other viruses would not be causing the same infection. So the home will have 2 viruses, but not every person will have 2 viruses.
Complicated. All right, Lou, that's good. Okay, Helen Claire and then Alan.
Thank you, Madam Chair. Through you, I just would like to confirm something that I think I heard Jillian say. Jillian, I think you said that the guidance now is if somebody is sick but needs to go out, it's suggested that those people wear masks if they're going into settings where other people are in attendance. That is what you said. Okay, I need some help understanding this. Is COVID itself now weaker? I understand that the risk in the community, to the community rather, is weaker because more people are vaccinated. But has COVID itself suddenly become lost some of its superpower. The reason, if you'll bear with me, I understand public health is about appropriate risk mitigation, but I also understand that there's less community risk because of the uptick in vaccination. But surely leaving masking optional for sick people who attend indoor events puts the people that are also attending those events at risk. We've gone from mandatory quarantine for 10 days with extraordinary fines for non-compliance, mandatory masking for the common good, to optional mask wearing if unwell. We haven't even been out of federal mandates for the Arrive Can app for a month. And yet now it seems to be very, very laissez-faire. So please, perhaps you, perhaps Dr. Ara, help me understand the rationale that supports this new guidance. Thank you.
Jillian, did you want to start?
Sure. Maybe I'll just start with making sure that my statement was clear. So when someone is ill, the expectation is you're going to stay home when you're sick. And luckily that covers both in COVID as well as influenza and most of our other illnesses, to be honest. So the expectation is someone who is symptomatic stays home at least until those symptoms start improving. And then upon resuming activities in the community, it's a strong should that masking be worn inside. So that's what the current guidance is from the province. And I'll pass it over to you, Dr. Ara, perhaps for that second piece.
Yes, certainly. The recommendation, the guidance comes from the province, and if people, through you, Madam Chair, sorry, if people are sick, they need to stay home. That's the recommendation. That's one of the cornerstones to the management at this point. The virus itself is getting less severe. Omicron by itself is less severe than previous variants. And I mentioned this before. It's probably for our audience who's listening to this board. Coronavirus is not known to humans. It affects humans, affects animals. There are 4 strains that affects human that we also know as common cold. It causes common cold. COVID-19 is a new strain that jumped from the animal world to affecting humans. And because it is novel, many people will be infected with it. And the progression of any virus through natural selection is to get weaker and weaker and weaker, because stronger strains will result in expiration of the host, the human. So it is natural selection that's driving this. And yes, the current circulating strains are weaker than the previous one. They cause less severe disease. With all this said, we need to be careful that individuals are different and their health condition is different. Somebody who's in their 20s that's completely healthy would not be affected as much as a person who's very old, or a person with other diseases or immune deficiency, or any condition that reduces immunity.
Helen Claire?
Thank you, Madam Chair. I guess this confirms what I understood, which is, and I'm not understanding why there's a rationale, what the rationale is, that suddenly we've gone from, we all have to look after each other, everybody needs to be vaccinated and wear masks, to a strong recommendation, which respectfully is a little like being a little pregnant. Either something is a recommendation or it is mandatory. So we've gone from mandatory to recommending, but we are still saying that there is risk to the same populations that just a short time ago, it was needed to protect them such that we had mandatory measures. So that's the bit I'm struggling with a little bit to understand. But thank you both for what you've said. I don't think I need to beat it up anymore. I do have a separate question, if I may, Madam Chair. This is to Dr. Ara, and it is with regard to the RSV virus that I'm seeing some headlines, and we have talked at this board level before about perception and the whipping up, the frenzy in community, largely exacerbated by social media and mainstream media. So RSV, now seeing this as something we should be afraid of, gives me some pause. As a mom of 3 kids, I only ever knew about RSV as something that was of concern when babies were born in hospitals. So I wondered if either Gillian or Dr. Ara could speak to RSV and whether or not this is something that we need to be suddenly concerned of in our adult population, or if it is indeed just media and social media doing what media and social media seems to do best. Thank you.
Gillian, go ahead.
Sure. So in one of the points in my presentation, it was mentioned that part of what I think we're particularly interested in going into this upcoming season is the potential of lack of immunity from natural infection to some of these other agents over the last couple of years, whether it be influenza, RSV, or rhinovirus. So I think all agents can pose a risk, and RSV, though we hear about it most commonly in children, it also has been the cause of some of our routine, regular respiratory outbreaks in long-term care homes that we've seen in those pre-COVID years. So definitely something that's on our radar. And when it comes to outbreak management, we would prefer no outbreak over an outbreak. But as far as the actual severity and impacts to children, I will defer on to you, Dr. Ara.
Through you, Madam Chair. Thank you, Julian. Yeah, I echo what Gillian mentioned. Regarding the severity, RSV is a very common respiratory virus. It affects, it's the most common cause for bronchitis, and it is concerning in children less than 1 year or in very old adults. It is not a concern of concern in other age groups. That didn't change. It's always been like this. I wonder if the media is just focusing on what public health work more than other years. And I actually just checked the CDC website to see if there's any change in the recommendation. There isn't.
Helen Claire.
Thank you both. That answers my questions. Thank you.
Right. Alan, you had a comment?
Yeah, thank you, Madam Chair. Just in listening to comments and questions from everyone, is it the position maybe of the health unit that they should be still promoting people getting vaccinated?
Through Madam Chair, definitely yes. Staying up to date with the vaccine is protective on a population level, and staying at home when sick. Those are the 2 main messages. And if I may circle back to Helen Claire's last comment, the recommendation or the strength of recommendation, at least from my office, did not change since the emergency was declared over. That Omicron is less of a severe disease. There is enough immunity. And we know that in the fall is going to be a surge, and we're concerned about that surge, and we're concerned right now. But the recommendation about the strength of the virus or the level of response, I don't believe it has changed. Around March, there was enough evaluation, 3 months of Omicron, and I would say the majority of medical officers of health look at the management of outbreaks in long-term care. Do we need to be as rigorous as we have been, since there isn't have been death because of COVID? And obviously these decisions and guidelines need to be conservative, and they need to change slowly. But even since March, I was comfortable to say that we're on the tail end of it. And again, the loosening of the guidelines provincially has been proceeding slower than what, in my opinion, should have been. I had the same messaging since April, since May, since the emergency was declared over, that the level of rigor need to be least intrusive, going from regulation to strong recommendation to recommendation.
Thank you, Dr. Ara. Anything further?
Madam Chair, just to follow up, so is the position then of the health unit, like, are they going to do some additional advertising and telling people we should still be getting additional vaccines? Because I hear on the street people saying, oh, they don't need to go, things have leveled off and we don't need to get more vaccines. Personally, I've had my fifth. So I would encourage, us to do some advertising then as the health unit that people still should be getting the vaccines.
Through you, Madam Chair, we continue to provide the clinics. We continue to provide messaging that is spaced out. So over the past 2 months, we did not issue too many media releases intentionally because there was messaging fatigue. So over the past week, we have been contemplating that we need to put not just for vaccine, but for awareness of the increase of number of cases. I had my first interview on the subject yesterday with Blackburn, and today there will be a media release that will go out to, or depending on the media cycle, to go on Monday. We need a bit more impact, but you're right on target. That's our goal, to increase awareness and a bit of concern in the community.
Luke?
Thank you, Madam Chair. Just to follow up on Al's question, Al's a bit ahead of me. He's on his fifth. I just got my fourth yesterday. Not sure how I'll be there in 5 or I got my fourth. But anyway, but on flu influenza question and vaccines for influenza, I went and got my shot yesterday and I was at a pharmacy, and when you sign up, you can sign up for COVID, influenza, or COVID and influenza. So I signed up for COVID and influenza, and you go there, you can only get COVID because, of course, for the general population, at least according to the pharmacist, they still couldn't access the flu shot yet. And I just wonder, because Al's right in my view, the advertising on the COVID shot needs to happen, but we're getting this messaging that flu is going to be a bad flu season, right? That's all the messaging out there. Everyone's hearing that. And we're seeing here that it's early, so we're getting some scientific data that indicates it might at least be longer and not worse. And yet I can't access the flu vaccine right now. I even signed up for it, right? Which is I'm going to be a pretty highly motivated client for the flu vaccine, but a lot of people won't be, right? If they're hearing that messaging and reach out and they fail on that, then are we losing some? We're starting to lose, so I get, because we spoke about this last meeting, your comment, which was that they're pushing it out because they want to make sure it stretches into March and April. I get that, but are we having some diminishing returns because everybody's hearing the message and they can't act on it? And so what's the odds they're going to double back and try again? So are you still, I guess what I'm asking is, are you still content that we are, a guy like me couldn't get the flu vaccine yesterday in Grey Goose?
Through you, Madam Chair, I am concerned, actually not content, that somebody would ask for the vaccine and they don't get it. There's a bit more layers to the distribution of the flu and vaccines to the pharmacy. Public health, historically until this day, provided the vaccine to primary care, long-term care, hospitals, and our clinic. The pharmacy came on board as a distributor of vaccines about 5 years ago. And until this day, the distribution takes place directly from the national supplier to pharmacies through the ministry, not through the health unit. During the pandemic, we actually broke the rule in Grey Bruce. I emailed the ministry and we said we're going to be supporting the pharmacy and distributing directly, because sometimes there isn't enough supply, or for some reason pharmacists needed that vaccine but didn't have it. And we actually supported them in getting rid of the nearly expired vaccines. As you know, smaller businesses, pharmacies might not be very eager to get large amounts unless they know that they can distribute it. Otherwise, it's going to be a loss. So we took it back, distributed through our clinics in timely fashion before it expired. So we did even go over and beyond to support them. I will be more than happy to look specifically into supporting that pharmacy to see how we can do it. With the flu, we don't have that permission to send them vaccine, but if we can support in any way, I will do my best to do that.
It just seemed like pretty much, according to what the pharmacist said to me, and of course it's just one interaction with one person, but we're not able to give it to you yet because it's not being authorized for the general public. It's still for high risk people until November. So maybe there's some confusion on, or maybe that, I don't know, that's got above my pay grade pretty quickly. But I guess all I say is that that's happening out there, and there's a motivation to get this thing from people like me and many others, I'm sure. We don't want to lose those people. I think we're better off to get them the jab in October, have it maybe run out a little bit early rather than lose them all together. So it would be great if public health to take some steps to make sure those folks get those ones.
Through you, Madam Chair, if I may, we have had vaccine distribution for influenza in Great Bruce since the start of October for all age groups, my understanding. So I don't know what the communication there, but I'll be more than happy to connect after the fact and support.
Right?
Just building on Luke's comment there, I know someone that works in the healthcare industry or primary provider, and they were having the same issues mid-October when influenza was starting to rise. The health unit said, no, can't distribute it yet. You're gonna have to wait till early November. What the hell?
Thank you, Madam Chair. I will look into this very seriously. This is not my understanding, but
All right, thank you.
Okay, good discussion. I think we can wrap this one up. Thank you very much, Gillian. All right, moving on. Item 9 is medical officer of health update. And the first one, Dr. Aaron.
thank you, Madam Chair. My update related to COVID was almost all covered by our discussion, which really indicates engagement from the board on this. But to summarize, there has been increase in the number of cases recently over the past 2 weeks that is concerning, almost double the number of cases we're seeing from 10 to 20 per day, number of hospitalization, the number of outbreaks in long-term care. So there is a move towards upping the message for the general public and to get the vaccine, to stay at home when sick, to use masks when a person is in a crowded environment where they're not in their household and there's no control over the 2 meters. So again, there is indication of messaging fatigue after 2.5 years in the pandemic. So we'll balance the two. We do have systems in place to respond to the management of these outbreaks in cases that does not require declaring emergency. And it is within the expectations to see this surge going up. We'll continue to monitor and support the different partners. So that's my update on the COVID situation, Madam Chair.
Okay, there is no update on the modernization, so please continue with the opioid situation.
Thank you, Madam Chair. If we can put up the slides, I have 3 short slides, just an update about the opioid crisis. We can go to the next one, and there is a slide on the local efforts, slide on good news on the provincial efforts. So locally, we continue to support the cause through different teams. The population health has been increasing its robustness in getting reports and data. Historically, over the past few years, we worked with the EMS, for example, to get all the data about emergency calls for opiate, but we know that there are overdose that the EMS might not get a call for. So recently we worked with different police services in Great Bruce to get a report from them and mutually support the data collection. Similar efforts on the fronts of surveillance with the emergency department, with the hospital, more or less on the type of data and the quality of it. So this has been completed, and we continue to receive this. Harm reduction team is working on data related to prescription drugs, illegal street drugs. Through the outreach, we can increase the quality of the data we receive. And the final one is working on different committees. And, for example, Grey County has a task force that recently had its recommendation. That's one of the initiatives that we're following, supporting, leading, depending on the circumstance. If we can go to the next one, please. On the provincial level, Dr. Zayed updated the board over the past few months about our contribution to the Como Council of Medical Officers for Health of Ontario working group. And she has been leading a group of 10 health units, co-leading it with Public Health Ontario. So one of the successes last week, we had agreement with the chief coroner office to receive data on mortality. So historically, we received the reports quarterly or every year, and now we receive it weekly. We have access to the data, the raw data immediately. And de-identified, and that started last week, which is going to be a game changer to actually know the location, the gender, the different data of the potential cause of death. As you know, the coroner finalize their investigation sometimes over 2 to 3 years to go back in the investigation and see if it's opiate or not. Now we have access to the front of that data. We can go to the next final slide. The other success for this group that Dr. Zayed is working on is a grant proposal for $120,000 to evidence-informed public health approach related to substance harm use among children, among youth in Ontario. This is the focus of the group, and her work over the past 3 months resulted into a submission that, although competitive, it was successful. And I just get quotes from the emails we received. So the work is progressing a step at a time. We always want to do more, and we want to get to the final finish line and putting a positive dent in this crisis or eliminating it if we can. But I do believe this is a multi-year work. And again, in 3 months, we have seen results on 2 fronts. Any question, opening the answers?
That's impressive. Very good. Brian.
Thanks for you, Madam Chair. Somewhere in there, Dr. You said we have overdoses that EMS would not get called on. That kind of surprised me. Can you give me examples? That number's got to be low.
We don't know what it would be. Some people might experience overdose, get naloxone, inject. Their friend injects them, save them without calling the ambulance. So these might end up in a death, so we would know what it is, or end up in recovery.
So this is actually routine for some to use naloxone and just bounce back and no 911, just getting.
Correct.
Wow. Thanks.
Are there side effects from naloxone?
Any substance, any drug has side effects. There's a saying in environmental health, the poison is in the dose. Even water, if the person drank too much, will have a side effect. Naloxone is a substance that should not be used unless indicated, but when the benefit of the intervention is saving lives, we will definitely look at the side effects as less concerning.
Right.
The thing about naloxone, thank you, Madam Chair, you correct me if I'm wrong, Dr. Is it's only a temporary, like you said, I don't know, it helps you for 10 or 15 minutes, right? Whatever the length of time until you get more. The overdose will continue if you don't get medical attention, right? Like it's not doesn't just reverse an overdose and then you're fine necessarily. Like you still have to. That was my understanding. I was weird about it. So I need to understand better.
It's through you, Madam Chair. It's a good question, and there's definitely, in an optimal world, we want to follow up with the care of the individual, but it might be sufficient to get them over the critical period.
Right. Any other questions or comments? Helen Claire.
Thank you, Madam Chair, and kudos to Dr. Zayed for approval, the grant for the project. And I'm very interested in hearing whether the project will involve going out to schools for kids. I'm aware of parents who recently discovered that their 14-year-old is doing drugs. And in these times when there's unsafe drugs on the street, just using it once, of course, could be that one time that's fatal. It isn't to do with how long you've done it or how serious or so on, as we are aware. So I'm really, really interested and hopeful that somehow we're going to be reaching people upstream instead of this overdose revive cycle that we're in right now, that we hear about every month. I'm wondering if somebody could speak to that project in a little more detail and give me that hope. Thank you.
Dr. Era?
Thank you for the question. Definitely prevention is key. In public health, whenever we tackle injury, we have two primary and secondary prevention. Secondary prevention is after people fell off the wagon and how we can reduce harm, but the emphasis on the prevention. And I realize over the past few years, harm reduction became less stigmatized, rightly so. But it's definitely not our focus. And in this group, one of my, I would say the most significant input or emphasis I put through Dr. Zayed is we need to have prevention in that process. Whenever we're tackling the issue on an individual level, harm reduction becomes essential because those are the people who are suffering. But if we're looking at population level, and that's what we do at this table, this issue is not going to go away or be reduced unless we go to the people who have not used drugs and prevent that use.
Okay, Helen Claire? Yes, good, thank you. Any other questions? Comments? Very good. I need a mover and seconder to receive the medical officer health update as presented. I have Alan and Brian O'Leary. All in favor? That's carried. Okay, item 10 is corporate services, and we have the financial report for August presented to us by Kim Rutherford. Kim?
Good morning. So for you, Madam Chair, these are some funding updates in the August financials. We received some good news in September relating to our funding for 2023. The Ministry of Health sent us some correspondence acknowledging the continued time and resources required to respond to COVID-19, as well as administer the COVID-19 vaccine. So that they've continued their commitment to fund COVID extraordinary costs for 2023. They've also extended the school focused nurse initiative, which for us is 9 nurses. They've extended that initiative until the end of June 2023. And then the last piece of the funding announcement was that the mitigation funding would be continued again for 2023. So that's the funding that offsets the increased costs to the counties with the change in the municipal provincial contribution between the counties. So that's good news there. So that'll continue for another year. So we'll communicate that to the county so that they can factor that into their 2023 budgets. Looking at our August financials, so we were in a surplus position of 405,000 at the end of August. We continue to be in really good financial shape. All of our mandatory programs and COVID program expenditures were fully funded, and we continue to have access to additional COVID extraordinary funding if we need to use it in the last part of the year. That funding's already been approved by the ministry, so it's there for us if we need it. The majority of the surplus at the end of August is from the seniors dental program. The program continues to take advantage of that surplus as much as possible. So they've partnered with 4 dental clinics and 4 denturists throughout Bray and Bruce to refer patients from our wait list to their clinics. And partnering with those clinics has reduced our wait list by half. So we started at just under 300 and we're down to about 125 as of today. And we're hoping as we continue to do this for the remainder of the year that wait list will continue to drop further. The team's also working closely with our purchasing department to buy some key supplies and equipment for the Walkerton clinic with that surplus. We are running into some supply chain issues. We wanted to buy some dental chairs, which are expensive, using the surplus, but there's a current like 10 to 12 month wait time on delivery on those items right now. So we are going to go ahead with those chairs, order them to make sure we have them for the clinic, but it doesn't help us with the surplus and using that money to pay for them right now. So they are buying other key items that they can get in-house before December with that surplus. So the team is doing various things and to position the program favorably going into 2023. If we look at our funding and our revenues, with the exception of the COVID extraordinary funding, we're right on track with what we budgeted. The reduced COVID funding kind of aligns with our salaries and benefits, which is under budget. We haven't had to spend what we budgeted for when it comes to overtime and extra hours for staff. So those are moving together. In August, we went to market for the purchase of some Microsoft license, 365 licenses. And so we awarded that contract to a successful vendor. So you'll see those expenses in August. And we also were dealing with our upcoming property insurance renewal, which saw some significant increases. So that's been captured in the August financials as well. And the last update would be the Walkerton Dental project. So we have an evaluation team meeting today, actually, to look at the proposals for the project management of the project. So hopefully we'll award that to a successful proponent in the coming weeks. And we're also in the final stages of reviewing a lease agreement for a potential location. If everything works out with the agreement and the space, then we'll be able to share the location at our next meeting.
Any questions for Kim? Brian?
Thank you, Madam Chair. Regarding the increased property insurance premiums, have we approached the insurer to ask if there's any measures we can take to mitigate the increases, or are we just, I know it's a hard market and all that business, but are we just going to pay the increase, or are we
No, it
prepared to
was,
push back a little bit?
it was a lot of back and forth between where we started. So we started at over a 50% increase and we ended up just around 34% by the time we were done. So there definitely was pushback on it. We asked if we could review, what is our deductible, what is our coverage limits. There's a lot of it that there wasn't really, it's just kind of what experience is being faced across the market. I reached out to other health units to see what their renewals are rate. They're the ones that have had renewals are also seeing significant increases. I fought them a bit on because of our higher staffing numbers. They're saying some of the premium increases because we have more staff here. And I said, well, that should have been reflected in last year's premium because we had that number of staff last year. So we had some back and forth on that. So we did end up lower than where we started, and there was a lot of pushback. We did talk about going to market, which might be more of an option next year. We have a couple claims right now that we're working through. If those are closed, then we would be more attractive to go to market for our coverage. The problem is there's only a couple companies that actually insure public health units. So you're really picking from one or two people for coverage. And then there's certain coverage that you're lucky if you have it right now. If you went to market and you change, you risk losing that coverage that you have now. So it's kind of a balancing act. It's a tough market right now. But yeah, I was not happy when I got the original quote for the renewal. So
Good, thank you. I'm heartened to hear that.
Other questions or comments? Okay, I don't see any. Please continue on with the risk management report.
Okay. So for you, Madam Chair, this is the 2022 risk management report. So this report is being presented to the Board of Health for information. As part of our third quarter reporting to the Ministry of Health, they asked that we report to them the high risks currently being managed at our Board of Health. They've created this template so that all boards of health are reporting in a standardized format, so they can kind of compare across health units the risks that we're all facing. So senior management put together the figure one in the report sent to you. So we identified and evaluated the risks outlined. The risks were measured based on the likelihood and the impact, and anything that was scored over 12 was determined to be a high risk and got included on the report. So we've identified 4 high risks to be included for 2022, and I'll just go through each one quickly. The first risk is the financial pressures that we're experiencing as everything's increasing with inflation, but our budget only grew by 1% this year. So, we're seeing it across the board. We're seeing it in health and benefit renewals, insurance renewals, collective agreements, utilities. So I mean, that's just a lot of financial pressure that we're dealing with, and we're going to have to somehow balance that going forward to maintain status quo operations. So it's going to have an impact, and we rated the likelihood as 5 because it's happening right now. We're living it right now. The second one that we identified was the potential for breach of privacy, loss of money, loss of trust, and or disruption to infrastructure from cyber attack. So we know that the attacks are happening more frequently, that they're trying various occasions. The goal is to stay ahead of the attacks with your investment in your IT, and your training, and your staff knowledge. So our IT department has definitely done a good job of staff training, educating, trying to keep our technology ahead of the game, but there is a risk there. And if they ever were successful, we had a ransomware attack, the impact we believe would be pretty substantial to our organization. The other one we identified, so similar to what was on the previous year, where we talked about modernization, while it isn't at the forefront of conversations right now, any kind of political discussion about public health, the structure of it, the funding of it, how it operates could have a large impact on our organization and how we operate. So we've identified that as a high risk. And the last one, it was on the 2021 report as well, was the potential funding pressures due to the revised funding contributions between the Ministry of Health and the counties. So the 1.1 million going to the counties. We've been fortunate that since it was announced in 2019, we had 3 years of mitigation funding. I suspect that 2023 would probably be the last year, maybe 2024. But then we'll start to, well, that change will take effect, and we haven't really seen what the impact of that will be yet.
Dr. Era.
Through you, Madam Chair, the first item, the funding, there is a bit more an update came from the ministry in the past 2 days after we sent the agenda. The indications that the increase for health units for next year budget might be by 1 or maximum 2%, far from the inflation rate and all the other aspects that would come with funding. So it's going to be tough years if there isn't push from public health, boards of health to the ministry to increase that number. I suspect we will see correspondences going from the boards of health to the ministry regarding this as soon as that is formalized or those numbers are concrete.
Thank you. Any questions or comments? Okay, I don't see any. So we do need a motion to receive the corporate services report as presented. I have Brian Millen and Stella. All in favor? That's carried. Thanks, Kim.
Thank you.
All right, item 11 is other business, and this is a discussion on health rebranding, health unit rebranding, and we have Nelson Phillips, our communication coordinator here. Welcome, Nelson.
Good morning, everybody.
One.
Okay, so yeah, it's been a minute since I presented to the Board of Health on our branding strategy. So just to reiterate, here's some project goals. So the goal of this project is to reimagine and deploy brand and embody our pride in supporting and protecting community health. Of course, those goals are to protect regional health and wellness and to inspire the longevity of community well-being. So here again is just kind of an overarching basis of what we need to have happen. We need a new logo package complete with primary and secondary logos and alternate colorways. We need to have that available to all staff. We need a complete branding package, which we don't have now. We've done a few of these things already. So, for example, we do have direction for verbiage and language preferences for messaging now. We do have some examples of real world use through some of the proposals that I've come up with. We have adopted some software. We are expecting more. We have an avenue for outreach and updates now through our internal newsletter. And we also have started work on a new website. This is a massive project with a lot of moving parts. Communications has been working in collaboration with our IT department here to start that work. And of course, we have been vetting content from staff, providing assistance with wording, and things like that. So as part of the proposal process for our rebranding efforts,
created 4 preliminary corporate brand packages with some select aesthetic assets only, namely the logo, with some explanations for the thinking behind each one. From there, the senior team met, we investigated what we liked and what we didn't like about all of them. And then we organized each brand in order from our favorites to our least favorite. We quickly eliminated 2 and began working with the remaining 2 packages based on popular opinion. And the plan was to deliberate these 2 finals and collectively decide on corporate identity and health one. I had decided that we were going to hold up in this room and not want to leave until we had decided on one. It didn't go that way, of course. What we came up against was the need to kind of deliberate the name. We've been back and forth on 2 different names. And we thought that this might be an excellent avenue to kind of explore what we were thinking. So just as a refresher, here's the outgoing brand. The text here is kind of a reiteration of what is included in the previous corporate brand package. So the current corporate identity, it was described as friendly and accessible when it was designed. It had the following keywords in mind: freshness, cleanliness, and safety. The colors chosen were to reflect growth and richness. The term "not trendy" was also desired. That was specifically mentioned in the package. Also the words "public health," which I believe we're collectively known now rather than the Greater Bruce Health Unit. We're kind of known as public health. I think we have a lot to thank for that. Public health is kind of dubbed to have been more important than our legal name when this logo was created. And it was agreed that projecting public health was less likely to change over time. I suspect that to be true now, and it would help differentiate between the other organizations that use Greater Bruce. So here's a bit of an environmental scan of some of our colleagues working across the province. These are some other health unit branding packages, just their logos really. Use of typography and color and symbology. I'll draw your attention to the fact that all of them except for one reference this geographic presence in their names. It's Simcoe, Muskoka, it's Thunder Bay, it's Huron Perth. We're much the same Greater Bruce Health Unit. Then I'll draw your attention to the Porcupine Health Unit here. That is the health unit for the Timmins area. It does not reference a geographic entity at all. So when senior management met a couple of weeks ago, we kind of went over this new name deliberation. And this is kind of where our approval process or our proposal process stopped. We had a really good conversation about it. So basically 3 modes of thinking here. Greater Bruce Health Unit, that is the status quo right now. It's well known, that's our legal name. If we were to remain with this, it would require very little rejigging of the brand in the long run. We also own GBHU.ca, which we could move to as we continue work on our new website. So yeah, as we rebrand and populate that. We also experience a high volume of misplaced calls each month that are intended for the Greater Bruce Health Services, especially during the pandemic. So Greater Bruce Public Health is one of the name deliberations we've explored. We're known as this as well, like we're known as public health unofficially, largely because of the current logo and its prioritization of that term, public health. That's a really good thing for us to create an easy transition. That's kind of low-hanging fruit just to be able to rejig and make that timely change. Public health as opposed to health unit for me as well. It's much more community focused, feels much more organic. From a marketing perspective, I find that to be very advantageous. Yeah, but it still can perpetuate this confusion between Greater Bruce Public Health and Greater Bruce Health Services. There's still a little bit of an overlap there. And then finally, one of the names that we've looked at pretty closely is Twin Counties Public Health. So I'm a local guy, I grew up here. Twin Counties is something that I grew up hearing a lot. Twin Counties is an old moniker for the region encompassing Greater Bruce. We have an extremely similar culture, economy, geography, population base, and identity. Twin Counties kind of eliminates the separation of Grey and Bruce, and it would also eliminate the differentiation between the 2 individual bodies. I think this would inspire a bit of a collective vision for the health of the regional population as a whole, because it emphasizes people and the region rather than each county itself. So I'd like to open the floor and have a bit of a discussion today, whether or not we like the idea of keeping Greater Bruce as part of the name, It falls in line with many of our colleagues working in public health throughout the province. It also strengthens the awareness of the area that we've seen through tourism and economic growth, through people moving here, particularly in the last decade or so. I think Grey Bruce is an area, it's a popularized name. It's kind of become a bit of an icon for our whole area. It also maintains the presence of both Grey and Bruce counties in our name, or we could change it to something a little bit more unique. Twin Counties again unites the counties under this new banner of public health. It aligns the role of the health unit to be more about health and prosperity of the people who live here, rather than simply highlighting those two municipal bodies. It can also help to reduce that confusion between us and other groups. Dr. Aaron and I spoke the other day. We were imagining if we still use the yellow pages, just how many companies or organizations would use Grey Bruce as part of their name. There's no bad companies. So this kind of gives us an opportunity to operate under a more unique banner. So with that, we'd love to open the floor and get your ideas on whether or not you think keeping Grey Bruce or moving on from that and exploring something different would be a good idea.
Thanks, Nelson. Dr. Aaron?
Thank you, Madam Chair. Thank you, Nelson, for that presentation. I just need to highlight a few things about this project. One, it is done in-house. We're not going out to a company from Toronto. And I really think this is an important thing. We are using local in-house talent to do this. One of the issues was mentioned there, confusion about the name. We receive relatively high number of calls, especially during the pandemic, about the hospital, about, for example, Grey Bruce Health Services. People are confused. Until this day, I would say on a weekly basis, I personally receive an email or two. What are we going to do about the management of physicians in the community? This is not under our jurisdiction in any way. Sometimes it's a bit more problematic where private information could be sent or healthcare information could be sent to another organization. So there was a breach because of the similarity in names. We received, for example, a package related to a patient who's seen in the healthcare sector. So we had to report that it's not our breach, but it causes confusion. In the future, if we create a charity sister organization to help unit to fundraise and take the opportunity of our presence in the community to bring funding that can actually support the community, you can appreciate that a mistake in sending the fund to a different organization would make us lose credit on top of the credit that we've been losing sometimes, where I hear about people thanking other organizations for the work that we actually have done. So again, that's where Twin Counties might be a unique solution for it. My understanding, it's part of the history. I didn't grow up here. When I heard it, I thought it's a unique way to refer to our area. Could it cause less presence of Grey Bruce as a term in the media or affect tourism? I don't know. Like those things are beyond what I can think of or investigate. It might even increase it. People talk about cottage country, and they always say it with a positive notion, but cottage country could be Grey Bruce or Simcoe or other places. So if Twin Counties in 2 years becomes Twin Counties, everybody would know that this area is Twin County. It could be a positive impact, but for now, we thought we'll ask the board for their opinion on this matter. Thank you.
Okay. Helen Claire.
Thank you, Madam Chair, through you. I'm not a fan of Twin Counties. I think that we solve an issue of confusion with the health services by pulling to the forefront what we do, which is public health. So I think by making that more prominent, that would solve the issue. I am a fan of rebranding, just to be clear, but I'm not a fan. I think going to Twin Counties throws the baby out with the bathwater. And although geographically this isn't an exact analogy, it could cause more confusion as people wonder, are we Kitchener-Waterloo, for example, even though those aren't counties, but they are associated geographic districts. Twin Counties could be anything. It's not unique to who we are regionally. So in sum, I am a fan of rebranding. I'm not a fan of Twin Counties. I think that the way to address the confusion with the health services is to bring what we do, the essence of what we do, which is public health, to the forefront. Thank you, Madam Chair.
Thank you. Yeah, I have Alan, then Brian.
As usual, Alan Kerr kind of stole thunder that I was going to say. I totally agree with what she had said. I think there was a day when the Twin Counties meant more than it does now. I think there's other municipalities throughout the province that have kind of partnered up with a neighbor, and they can be referred to as Twin Counties. So I'd be afraid we would get lost in the shuffle doing that way. And but that was my support too, would be to go behind the Grey Bruce Public Health name.
Brian?
Thank you, Madam Chair, and I'm sure O'Leary would want to call it the Owen Sound Health Unit, but we're not gonna go there. Maybe we could call it God's County. God's County Health Unit. No, I'm kidding. I like the notion of rebranding, because there is an element of confusion, I'm sure, with health services. But I'm not sure, Twin Counties need to grow on me a little bit more, but were there other ideas that came to the surface, so to speak, in terms of names, or?
No, those were really the ones that we focused on,
Right.
whether or not the basic gist of it was, do we keep it something geographically based, or do we move to something?
Right.
So Twin Counties is the one that we've kind of been flying that banner over, and that's, those are the two considerations.
Right, okay. Well, I'm not prepared to throw it out yet, but it will need to grow on me a little bit. That's kind of where I'm at. Thank you.
All right, Luke?
God's County.
Which county is God's county?
Well, that's pretty clear.
I'll let it, so, and I spoke about this last time we talked about, I guess my perspective is a little bit different. I just don't get the rebranding. I don't get it. We just went through the pandemic. This brand is more recognized now than ever, the current logo. It says public health up top, still has health unit in it. You know, we got a huge amount of brand identity for free out of the pandemic. We're just gonna throw it away and cede the title to Grey Bruce Health Services. Why don't they change? Like like what, you know,
Yeah.
why don't they become hospitals, Grey Bruce or something? I don't know, but I don't see, like, it just seems like a bad idea to rebrand at this moment. It would be like, it's like the new Coke. It doesn't make sense. You know, we built this up and we've got it now, and then to dump it. And also, and I get we're doing it in-house, and I appreciate those comments, but it's gonna be expensive to do. You're gonna change you're gonna change the website, you're gonna change every header, you're gonna change the brand on all the cups, right? It's gonna cost money to rebrand. And we just got finished, we just got a report saying, well, we're gonna get a 1% increase, and then we're gonna go and change the brand, a good brand, a built-up brand. End up with less recognition than we have today. And have to spend money to build it back up when we have the recognition for free. The whole thing is, I guess, and I'm probably in the minority, but I just think the whole thing's a bad idea. So, my view is keep the current brand, keep the current logo. And if it's confusing, well, we should call Grey Bruce Health Services.
Dr. Era?
Madam Chair, thank you for the comments around the table. Just on the final one, we are moving to a different website with the systems that we use would allow us to go through. I don't know the technology behind it, but we are moving to the website, the new one anyways. So all these changes will take place. We always update our forms, we always update so the cost is really not there, not different from regular operation. Yeah, the other parts of it that we have gained, people would know us during the pandemic. I don't think we're throwing this away. We're actually focusing. We're building on it. People would know who we are. So now we're putting a unique logo, and when people would see it, the logo itself, the issue is in the design of the logo. It's not memorable. Any one of us, I mentioned before, if we not look at the logo and try to draw it, it's almost difficult. Like unless probably Nelson is the only person who can draw it from memory. And you look at impactful logos, they're very simple. Mercedes, anybody can remember it, recognize it from across the road. Versus ours, I actually look at, you can recognize it on restaurants. That's the most location that you can find it because it's right beside the door. But again, I recognize it because I've seen it and I know it and I know where to spot it. If I see it somewhere else, it's not catchy. And that's the essence of branding.
Yeah, so again, I just don't agree. Like, I think it's out there. It's all over the place, and it's, is it the best logo ever created? You know, is it the Nike swoosh? No, but it is where it is, and it has an appearance, and people recognize it. And the pandemic has increased its extent to which it's out in front of the public. So I don't know, like, I think you can change it, and you'll end up with, you'll still won't get the Nike switch. You'll end up with a different configuration of words and images, and it'll still be what it is, right? Except it'll be different, and it'll be less recognizable because no one will have seen it. So I just think you're spinning around, and although I concede it won't probably be millions of dollars, there is a cost, because there are physical items that contain the logo and will change over time. So anyway, I that's my view of it. Thank you, Madam Chair.
Great. Brian?
So I'm somewhat in agreement with Luke, but just when he says I don't get it, because I don't get it. What I do get is there's a skill involved in marketing and branding. And respectfully, I don't think any of us have that skill. But we still have an opinion, and I'm not sure what the opinion is. When I talk about the committees that I sit on, public health is one of them. I don't think I ever say Gravers Public Health. That means nothing to me, but it's both counties. It's just public health. I don't feel like I should have an opinion because we don't have the skill set, but that's just me.
Thank you. Anyone online? Yes.
Hi, thanks. I kind of agree with Luke too, that I just don't know why we would change the branding right now, because it's, I mean, we've been in the spotlight for a couple of years now, and it does talk about the two counties, and I would rather see it just stay status quo. Thanks.
Now we got Bruce against Greg.
God's gonna have to choose, yeah.
Thanks, Janice. Solon?
I like Grey Bruce Public Health Unit. I think the word unit distinguishes it from a hospital, and people know the PHUs, right? Like they almost say PHUs, Public Health Unit. So if I'm looking up the hospital, I'm probably going to be flagged by the fact that word unit is there, so that I can distinguish between the two. But I like the idea of having Gray and Bruce, or Bruce and Gray, because it says who we are, and it is an area focused thing, and there are many PHUs in Ontario, and we're one of them. So we are Gray Bruce or Bruce Gray PHU.
Thank you. Other comments? Brian?
Sorry, what do we call the building across the water? Isn't it the unit 2?
Family health team.
Family health team, okay. All right.
Did everyone hear that? Brian O'Leary asked what we call the building across the water, and it's called the Family Health Team building. I myself have been guilty of going online and typing in Grey Bruce Health, hoping that it would come up. It eventually did, but I did get on the Grey Bruce Health Services hospital site at times, but throughout the pandemic, as it was more hits on the site, it came up every time. I put Grey Bruce in. So. Alan?
So just to be 100% crystal clear, I guess our official name then is Grey Bruce Health Unit. Clear, am I correct in that?
Yes.
But for example, on the mugs is saying Grey Bruce Public Health. So we've intertwined the two of them so close. Personally, I don't see a big change in going to that logo or to that name, the Grey Bruce Public Health. I don't see a big change to that from what we currently have. I just thought it makes it a little clearer to go that way. But I think they're so close between the two of them. So you know, I respect everybody's opinion on, it, but I think we intertwine the two of them, so going with one or the other is not gonna make a big difference. I just think the public health part helps the general public realize that public health is our mental.
Okay.
But yeah, I guess that's what is our logo. Is that our logo? Which says public health.
So, Nelson, did you want to comment or did you want further?
Well, sure. So, yes, keeping it kind of similar, at least doing a brand update is an advantage of that. So, we don't have to completely go up with something entirely different. We do need a new logo. Brands are constantly refreshing, whether you see it or not, whether you kind of appreciate the brands do that, but for example, like the Apple logo, the one we see today is not the one that started it all. So brands are constantly refreshing and constantly updating. It's something that's to do with audience engagement, with trends, with design aesthetic. It's just something that kind of needs to happen. Brands are not set in stone. There is always a need to update. As we do our new website as well, new technology, new abilities, accessibility, et cetera, like all these things need to be considered. Doing a brand refresh, looking at some rebranding, I think it's very important. In terms of the name, yeah, Rivers Public Health, it's very accessible, it's familiar. That is an advantage to us rather than changing into something different. So all great feedback. Thank you very much.
Okay. Dr. Aaron?
Thank you, Madam Chair. So I'm just gathering, correct me if I'm wrong, around the table, there are different opinions, but the majority of the opinions is to keep public health in the name and Grey Bruce Public Health.
Yeah. Okay, Brian?
Thank you. I agree with Luke that, you know, we have built up that measure of familiarity in the community with those 4 words, Grey Bruce Public Health, however you want to arrange them. And, you know, I also agree with Nelson that, you know, refreshes are, you know, they happen. So any refresh that does happen, as long as it's not unfamiliar to someone that was, you know, knows the old name or the current name, I think that would, you know, perpetuate that familiarity that we have built up through the pandemic. So, I mean, I'm not opposed to a refresh by any stretch, but I think that phrase is very key.
Okay, Dr. Aaron?
Thank you, Madam Chair. Just to add one more point, in senior management, the group looked at it and it's very consistent with what the board is validating, that Grey Bruce Public Health. The Twin Counties seemed like a nifty idea early on. After talking with senior management, it was diminished. And it's unique what you mentioned about the different drift versus shift. That's in the vaccine for the influenza are the 2 terms. If the virus mutates completely at the shift, the vaccine would not be a good match. And probably there is some analogy there to keep the momentum from the public knowing our name.
No, you can't have one sound in the name. Stop.
Okay, Sullivan, then Brian O'Leary.
So, thank you, Madam Chair, and I repeat, the word unit, to me is important. Because there are lots of groups, you know, focusing on health around the public. And I know that you can say public health, but when you say the public health unit, you're referring to this specific place, this entity, you know, this function, which exists throughout the province. So I stopped there with that. And at some point, this is an sort of an off take. Are we Grey Bruce Grey? At some point, we're going to have to come to grips with that because provincially and federally, we're Bruce Grey, Owen Sound. And I think it's sometimes confusing to people, you know, do I type Bruce first? Do I type Grey first? We're known as Bruce Grey, Owen Sound. Maybe we should be coming in line with that. I'm not suggesting that we go and, you know, make a big change simply because of that, but I'm just saying while we're at it, we should be thinking about what are we for a territory? We're the territory, I suppose, or riding of Bruce Grey and Sound.
Great. Brian O'Leary.
I just want to say I appreciate Nelson's comments, like the Apple example, I would never have known that that logo has been changed from day one. But obviously that's what they do. If they refresh the branding, that's what's more important rather than the name change. So why change the name? Just do a change in the branding. And leave one sound right out of it. Is that what you wanted to hear, Brian?
Make sure the minutes say.
Okay, any other comments? Helen Claire.
Thank you, Madam Chair. Just wondering if we can't help solve the confusion issue with health services by something old school, like asking them to put on their website and possibly their phone messaging, if you want the Grey Bruce Public Health Unit, please call blah, and that we could do the same thing. There's always going to be, if you try to book a hotel, for example, through the hotel website, you have to really pay attention that you don't accidentally get shifted on some kind of third party thing. So this confusion is a separate issue that I think it behooves us to look at going forward. And then my final comment is that we could also look at search engine optimization as a way of making sure that keywords that go in put us at the top. Sorry, I said final. I have one more thing. I think our legal name might be Grey Bruce Health Unit Board. Rather in terms of the board, I'd have to look at what the province says. But I just think if we're changing anything, we really need to make sure that it's in alignment with what we actually are. Thank you, Madam Chair.
Okay, good. Brian O'Leary.
I'm just wondering if we're gonna have a motion, if we could have included in the motion Luke's idea of just what's wrong with asking the Grey Bruce Health Unit or the hospital if they have any appetite in changing it, that we've had a lot of feedback where there's confusion and we're doing this branding refresh, and just wondering if they had any appetite in changing their name or making some kind of an adjustment.
They might be going through the same process.
It's worth asking, and all they can say is no.
And I don't believe Nelson was expecting a motion with direction. This was just for information, right?
Yeah.
Nelson, to give you more ideas and suggestions.
Definitely, yeah.
So he's got an idea of where the board is going with this. Anything else you need, Nelson?
No, it's great feedback. It's kind of along the lines of what I expected. I do like Grey Bruce Health Unit. I do like Grey Bruce Public Health. And so did senior management when we met. It wasn't like we were 50-50 here, like we changed it, we stick with what we do. I think, yeah, maybe a brand update or a refresh is a more appropriate way of kind of giving this a brand of its own. We're not changing everything from the ground up. We're simply refreshing it. It's going to better reflect our corporate culture here, how we're perceived in the public, and certainly SEO, keyword recognition, how we're found online will be explored more and kind of put to good practice as we redo our website, that kind of thing. It's not typically a best practice for a rebranding initiative to ask another company to change their name. It's kind of on us to make ours stand out, and that's what I'm going to do.
All right, Dr. Ayer.
Madam Chair, just one point about the legal name. The legal name is, I don't believe it has health unit on our credit cards. It's the Board of Health for Grey Bruce, I believe. Correct me if I'm wrong. I see that the legal name, so the health unit wasn't part of it, just clarity.
Okay. All right, good discussion. You have our input. We look forward to you coming back.
Thank you, appreciate it.
Okay. All right, does anyone need a break, or we'll just move into in-camera? All right, item 12. This is where the amendment was on the agenda. It has been recommended.
Still say the recording. Are we?
Yeah, right now we are, yes. Yeah. It has been recommended that the Board of Health meet in closed session pursuant to section 239(2)(e) of the Municipal Act 2001 related to litigation or potential litigation, including matters before administrative tribunals affecting the municipality or local board to discuss potential legal action against external parties. So I need a mover and seconder to go in camera. And I will take Selwyn and Brian Millen.
We need a motion to adjourn our regular meeting for today. Moved by, let's see, Brian Milne, second by Brian O'Leary, that we adjourn the meeting. All in favor? That's carried.
Okay.
Thanks, everyone. Thank you. This is the last meeting, obviously, for this board, because I